Thank you very much. And after that exciting talk by Dr. Ishmael, I'm going to try and bore you to sleep now. I'll be talking about the comparative pharmacokinetics of Dolutegravir in children with HIV, with and without TB co-infection. And I'll be presenting for the PK study team from the Comparative Teaching Hospital where I practice, the Kwame Nkrumah University of Science and Technology, and the University of Florida. There are no conflicts to declare. We know Dolutegravir to be a second-generation INSTI, which is an integrase strand transfer inhibitor. And DTG is metabolized by these two enzymes, with UDP glucuronidase transferase 1A1 being the major contributor. Rifampicin also we know to be an essential component of first-line anti-TB regimen due to its sterilizing activity. It is also a potent inducer of these enzymes. We know from previous studies that co-administration of these two drugs leads to reduction in DTG, area under the curve, and the trough concentrations. When given twice daily, DTG with rifampicin achieved mean area under the curve and trough concentrations that were 33 and 20% higher respectively than once daily rifampicin in adults. So in our study, we sought to compare these PK parameters and safety of DTG given twice daily in our children and adolescents with HIV and TB co-infection, comparing them to those without TB. So when you look on the study design and endpoints, the upper part talks about those with a TB co-infection. So we took children and adolescents with HIV, weighing 20 kilograms and above, not previously exposed to DTG, and they were put on double-dose DTG-based antiretroviral therapy as well as their rifampicin-containing TB treatment. And sampling was done at 0, 1, 4, 8, 12, and 24-hour post-dose after 4 weeks of this co-treatment, a minimum. And at the end of TB treatment, 4 weeks after the end, when we expect DTG to have been washed out, we resample the DTG pharmacokinetics. For those not on anti-TB medications, we just did the sampling at 4 weeks and 6 months. Our primary endpoints were we sought to compare the plasma area under the curve of DTG between the two groups. So this graph really just, this table, really just seeks to show that there's an increasing trend of, a trend towards increasing Dolutegravir area under the curve concentration, as well as C trough in those with TB co-infection. So our conclusion was that there was the plasma exposure and trough concentrations of Dolutegravir were similar in both populations, treated according to the current WHO guidelines. And DTG twice daily dosing is safe for children with HIV and TB co-infection, and there were no clinical or laboratory side effects within the study period. Thank you.